Great, thank you. So you heard three, I think, pretty intriguing bright spots of stories around the country. We'll open it up now to the audience for comments or questions. Susan?
Thank you, Peter. Susan Denser from the Consensus Committee. So I was struck by the fact that only Mark said that of ThedaCare, the question was asked of a patient, do you want to be seen today? And I'm wondering why the other system, Cincinnati Children, and Andy, we both know Dartmouth-Hitchcock, why that wasn't the case. And particularly since we also both know Dartmouth-Hitchcock, and we know that patients were waiting not days, but sometimes months for appointments, why not start with that initial question, do you want to be seen today? I'd love to hear the arguments for not asking that question.
Well, Susan, it's great to see you this morning. Thank you. It's always hard to have someone in the audience who knows your system as well as you know your system. And thank you for all the service to the institution. I think there's absolutely no reason why we don't ask that question. But before we ask that question, we need to make sure we can provide that service. And in fact, it really has to do with what is the capacity, and then how have we structured our scheduling. And I can say that there are efforts underway to deal with the completely unacceptable waits and delays. When I'm back in the community, I continue to hear from friends and colleagues how hard it is to get into our system. And quite frankly, it's embarrassing to me. And I suspect many of you, then individually and personally step in and try and help. And in fact, that's the wrong answer. We actually have to improve our system. So I'm embarrassed on behalf of the broader system. We should be asking that question.
Thank you.
And I would note that, so we do have divisions probably within our environment that do, our primary care, for example, that do ask that question. I think for us, we're always trying to strike the balance of, again, of this supply and demand, of trying to find that sweet spot, because all of our providers, as salary providers, we're very transparent about the data. You are, moving back to that effort, we have, whether it be you're in research or administrative or academic time, whatever that is, that's a puzzle that we put together to try to make sure, and that each doc sees whether or not essentially they are funding themselves, so to speak. And so we create an environment in which we're trying to strike that balance that gets us as low as possible while not having idle physicians, right? We have some environments in which we are finding ourselves with gaps in the system, right? And nobody really wants that from our perspective in terms of, but it is trying to get to that, how do I have a maximized resource at that sweet spot? And it's just very tenuous. And so I'd say that's sort of the practical side of it. I mean, I realize that from a spirit perspective, absolutely you are right. I think that we are, our effort is to constantly push it towards that while not being wasteful with our resources.
Great, okay. Go.
Yes.
Yes, I'm sorry, I apologize.
One of the things that I see, sorry, in the microphone. One of the things that I see in the, that helps. There, is that better?
Much.
Thank you. Sorry. Christy Dempsey, Chief Nursing Officer for Press Ganey. One of the things that I've seen in my work across the country with med practices and with operating rooms is that one of the fundamental problems is there is no truth in scheduling. We have maybe 2 visit types, and it's either 10 minutes or it's 20 minutes, and rarely is that the real amount of time that the provider or the patient spends in the room. So what are you doing around that piece? Because that's truly pervasive.
Right.
That's a great question. I'm going to just expand on something I touched on earlier, which is the way we actually build our schedules. In contrast, now understanding that keeping visit types down is a priority in terms of simplification, we actually do measured face-to-face times on all our clinicians, as much waste extracted out of that process as possible, and then build our templates based upon that. We've actually found through our studies that the use of short and long appointments, whatever they happen to be, has very low correlation with the actual amount of time needed to deliver that particular service. So it's comes close to collective delusion about how these schedules are put together, and that's why we've actually started with the clinician as really the pacemaker of that clinical microsystem, then built the schedules based on that.
Thank you.
Great. You know, your comment reminds me of, I was speaking with one of our anthropologists and an architect who really challenged us to say, why is the hospital room focused around a bed? If you wanted to think of a way that would keep someone sitting down in bed, you've designed it. I mean, you know, and in some ways I wonder in the ambulatory visit, that whole concept that wellness is in that visit and not at home or in other places, I think there's some interesting metaphors there. Chris, you had a comment.
Yeah, it kind of ties into what you were just saying, Peter. Maximizing the resources and optimizing scheduling system will increase availability and access to the system. However, it may have some unintended consequences. I wonder if anyone on the panel would want to comment on overbooking of patients, prolonged wait times, for example, for immunocompromised patients in overcrowded waiting rooms, extra cost for patients on lost time, parking, time away from their family, and ability to actually do better at home than sitting in a waiting room.
Wow. Yeah, it's. I mean, I think there are a number of opportunities in that regard. I don't think we have necessarily, we as an organization haven't cracked the code on the wait time issue. I think that the reality of it's your balancing measure, right? If you're measuring access, you could solve your access problem by bringing everybody in at once, but that truth in scheduling spirit has to be part of it, and why we monitor the percent of patients that wait, whether or not you saw your provider within 15 minutes. I think that how we have, we've begun to try to explore how do we begin to monitor I like to use that word fragile, right? Even a clinic environment, you take one patient who you thought would be a simple, straightforward appointment, right? And mom comes and she brings all of these complications that we didn't know of. We could have done things on the front end maybe to have discovered that, but then it has implications for everyone else. We have done some strategic overbooking. Tara talked about it in placing these patients who are most likely, when we did the analysis of who is most likely not to show, I know people want to attribute that to a payer source, and it's actually is the number one factor is whether or not you didn't show before. And so when you keep that history of people, then you can place them on something that in an overbook slot that says, you know what, there's a good chance that they won't show. And so so that helps to produce that environment. So that's how we've begun to leverage who do you think is best, most appropriate to implement such a strategic overbook.
And I wanted to say on that too, with monitoring that and tracking that, that was able to help the flow throughout, like say, a morning clinic. It was able to help the flow because we put those at the end of the clinic. So, and I think clinic flow is just a work in progress. So I don't know if we can fix that today, but.
I wanted to also take a crack at that, Chris. The opportunity to not see the patient, especially as various new reimbursement models change the drivers. Patients can do a lot from home. We can use video methodologies to do additional things with some patients, even in some alternative settings. And then I would be remiss not to acknowledge in individual clinics, leaders in our organization have done tremendous things, such as our spine center, where a patient with undiagnosed back pain goes through a series of questions with validated instruments, and then that appointment gets directed to an appropriate provider that may not be the clinician that the patient would have chosen on their own. And so those are important things. No matter, for examples we have already heard about, there are going to be times when patients sit in a waiting room. It's not a great thing, but how that time is managed is very important. And I'm not suggesting we do this well, but communicating with the patients is absolutely essential. Providing other things for the patients to do while they're there. If there are, again, patient-entered opportunities, they feel a whole bunch differently when they're actually doing something rather than just sitting there reading the 6-month-old magazine that was been there forever. So I think it's a little bit more customer service that needs to be what we end up doing to address some of those.
Thank you. Don has a question, and then we'll go over here.
Thanks, Mark. Mark, I have a question for you. You triggered a thought I've never had before, but you reminded me of something that I think Joe Duran wrote in one of his books. He said that processes can be characterized by something critical to the process, and they're differently classified. So there's information-sensitive process, time-sensitive process, knowledge-sensitive process, setup-sensitive process. I think there were 7 or 8 categories. And you used a phrase like this in passing. You talked about, I think you said time-sensitive or relationship-sensitive. Is that, did I get you
in
right?
that setting, Don, I was specifically referring to patients and their needs in a particular setting.
So my question is, if you could deepen that conversation just a little more, have you thought about classifying visits in terms of, in that kind of way? Maybe that's a pretty powerful way to think.
We are just getting to the point. I mean, one of the powers of value stream thinking is that it integrates all the flows, and that is essentially the way that you can identify and remove waste and make the processes more reliable. I wouldn't say we have gone to the point of categorizing processes based on that paradigm, as you mentioned. It's a very interesting idea. Thank you.
Right here.
Patty Gabbo, formerly of Denver Health. I have 2 questions. One relates to something Andy said, is that I think we know that there are a great many visits that could be handled non-face-to-face. And how do we think about that in a real-time scheduling system in where when the patient goes in for a visit, one can identify at that point that it may not require a non-face-to-face visit, which leads to the second part of the question is, do you think it's possible to maximize efficiency if you don't centralize scheduling, if you leave it to every clinic, every clinician, every division, no matter how much standard work you try? And I think this is particularly relevant to the VA situation. I don't think it's possible, given the forces of nature and entropy, to let every clinic and every doctor do their own scheduling. So could you talk about both of those pieces?
It's a really interesting point because the would you like to be seen today is based on the visit paradigm. So generally the products we produce are based on how we get paid to produce those products, and we tend to emphasize those products that we get paid to do. So hopefully, as we start thinking about value-based reimbursement, that will change and allow us to actually deliver the products that the patient needs, regardless of how we get paid to do so. I don't know if it's possible, but I would say it is advisable to centralize from the standpoint of the technical do you need to be seen today process. That is more of a sorting process that has to do with trying to schedule and available resources. I think that the more classical triage function does require some connectivity to clinicians who have background with patients and understand what the patient may or may not be saying in their the information that the scheduling person is getting over the phone. So I would perhaps separate the scheduling function from the triage function and indicate my support for centralizing the scheduling, but getting the triage function closer to the clinicians.
Great. Hey, we'll go over here.
Real quick, I just want to say that I am biased towards centralization, and I would say that we have some divisions that are not centralized in our scheduling center. They tend to be ones that for whom there's a clinical assessment and judgment done at the point of scheduling. But I would say the area that I would say is important for centralization is who is designing and maintaining the physician templates. So that's where all the insidious creeping in of the rules of I need an hour for a meeting in the middle of clinic, and those are the things that need to be managed pull that out of that environment, I think.
Great. We'll go over here.
So I'm Krasinski. I'm an internist and newly at the AMA. And so I've heard two mental models here about addressing scheduling. One is the schedule itself and sort of the science of scheduling and metrics and the template. The other, I think, we haven't emphasized as much as we could, and that is increasing capacity. And because I don't think it's really about the schedule, I think it's about the system. And so when we think about increasing capacity, I did hear at Cincinnati where you added providers. So one way we can increase capacity is to add more providers and alternative providers. But another way that I'd like to emphasize that I heard Mark saying, and I want to affirm it, is to re-engineer waste out of the system. And by doing pre-visit lab, I know at ThedaCare you save a lot of time. In our own practice, I think that saves an hour a day. When you think of the capacity that you generate, if you save an hour a day for your physicians, that's enormous. Just in primary care, that's 80 million visits a year across this country. And that's just pre-visit planning, and we can do it in many other realms. So I'd like us to also keep our minds open to eliminating waste by re-engineering how we do our work or not doing work that no longer adds value.
Great, thank you. We'll go back here. And then...
So I'm Mike Davies, and I'm absolutely sure that I have the most enviable job in this room as a director of access in the VA for the last year. I would like to ask a couple of things that I haven't heard you talk about, specifically about measurement. And just preface this by saying the VA's information system is 30 years old, and we've talked about the need to balance supply and demand. The system is really unable to tell us what supply is. So VA has been required to go to measure individual patient waiting times, which I doubt any other system really does. So we're measuring timestamps between events, essentially. And now, as you may know in the Choice Act, it's required by law. Right. So we're going to be faced with figuring out how to report to every patient, their patient experience and match it with the administrative system timestamps that's going to have to correlate. The second thing we're faced with, I think, is just a huge system that needs to have data and information that's accurate and reliable, and not, if I can say, something that can be manipulated. So I think that leads to two questions I'd like to ask. One is, what's the best measure for waiting times, especially if you're going to measure individual patient waiting times? And how do you guys make sure, and gals and everyone, make sure that the data that is in the system is true and not untrue?
I have one suggestion for how you make sure the data is true for an individual patient. Let the individual patient have access to it.
Well, I think that you're asking a great question. So this is one of the areas that we are constantly looking for the system solution, right? I think that how we track a patient through their clinic experience, we to date can track and do the time from there are certain landmark events in the course of a clinic visit, right? And we can measure the time from the time that registration ends to the time that a clinician begins to document on the record, right? So that begins to get at how long did you wait? That's our proxy measure for how long did you wait in the waiting room. We have not yet gotten to the knowing how long did they wait in the exam room, right? On doing it as an extremely manual process, which you can do for short periods of time, but isn't sustainable on a long-term basis. Really, that element. That I think is what our biggest struggle is sort of knowing what goes on after the patient gets pulled out of the waiting room, and knowing how much of that time is meaningful time.
So, and I think your questions are spot on, because that's a whole. I mean, much of our calls have been discussing this. What are the best measures and standards? And I think there's a lot of good thinking that needs to go on, because whatever you choose will force your mental models in a certain directions and will have consequences or implications for some other things. So I think it's a great question. In the back.
Yeah, Steve Lawless from the Moores. I'm struck, or I'd like to get your opinions on the difference between optimal versus efficient and the trade-offs involved in both, and the perspectives when you're convincing others of that difference of optimal versus efficient. Efficient could be more of an internal phenomena. Yeah. Optimal has to be from the customer's perspective. So how do you guys deal with the trade-offs of those two?
I'll give a specific answer to a general question. To me, it all starts with the voice of the customer. That's the standard upon which we base either of those. I think that optimal would better reflect the voice of the customer than efficient. Efficient, I believe, is an internal measure that has to do with how do we keep our costs of care down, and because the seconds that we need are all around us. You know, I mean, there's a lot of waste in healthcare that is invisible in plain sight because it's activity masquerading as value-added work. So I think efficiency is our challenge. I think optimal is, I would look at it more from the customer standpoint.
Okay.
My name is Rick Dart from Denver Health, and I'm a physician. I'm over all the call centers that Denver Health has, thanks to Dr. Guilbeault's efforts many years ago. It's an acquired taste, as you probably already know. The question I wanted to ask was about the same-day patients and sort of how call centers are organized. So at Denver Health, they all report to me largely. There's a couple little ones that don't, but that includes medical interpretation, appointment centers, nurse triage lines, that type of thing. And when a patient calls and says, I want to be seen today, one reason for that would be that they have symptoms now. There's an acute health event that they want taken care of by their provider. So why don't we take care of it right then rather than making an appointment for them? If you link, we've done some work on this, and at least in our system, about a third of those patients, if we link them immediately to the nurse triage line, will have their care completed during that visit. They're done. They wanted relatively straightforward things, sort of an acute event and a chronic patient, if you will, that can be taken care of without necessarily going into a clinic or another venue. Does anyone do that? And I guess I wonder about the integration of different call centers to keep away from the silos that an appointment center can be.
We have what I would describe as a semi-centralized model. We have most of our ambulatory groups have call centers that, again, because of the proximity to the clinicians who have the long-standing relationships with the patients and can often help guide care based on those relationships. We have, I would say, distributed call centers that I would refer to as, in lean lingo, as minimally staffed In other words, staffed for average demand, and then we flow to a centralized model for peak demand, and that helps us manage that balance between responsiveness to the patient customer, efficiency, and productivity.
And from our perspective, we have our relationships between a centralized environment and the individual divisions are very tight. So, so when calls come in for ill visits, we have access to clinicians then and there that can provide that. Some we are empowered to put them in. Other times, but to your question of how do we maybe avoid it altogether, we have access to division-based resources that enable us to connect them and potentially ask that question.
All right, there's a question in the back.
Ken Wood from Geisinger. This question would be for Cincinnati Children's. I guess I'd wonder if you could expound upon the idea of your scheduling algorithm that you use to effectively match supply and demand. Is this mathematically modeled, computer constraint logic, mixed integer programming, or do you have no-show predictive models? How do you actually, if you mind talking about the secret sauce of your algorithm and how you got there?
Yeah, I mean, the algorithm is really a way of just sort of thinking of, it sort of puts all of our learnings just on one page, right? And helps you go through that checklist that I said of what it is we monitor. This is basically asking you the questions of, are you at the threshold you want to be? And if not, what is the intervention that is associated with it? So, so I would say that the where you want to be is based upon our years of experience of trying to balance everything. And so do we have systems that create that? I don't think there's a system that takes you all the way through that algorithm. I think the supply management tool that Tara spoke to, that you've got some images in your slide that really manage that. I think we have different systems that help us to answer those questions at the individual division level. But fundamentally, that algorithm is just 10 years of work put in on a single page. Really, it's and that is our effort to try to make sure that everyone is thinking about all of those balls to juggle.
I was going to ask you, what was your question regarding the no-show?
Well, I mean, as you look at one of the listings in the slides was no-shows. So do you have actually derived from your EHR characterized predictive models to effectively then define the sort of constraints with your scheduling? Is that all mathematically derived from a program, or is that sort of heuristically based on who might or might not show?
Well, our system actually tracks how many the family's patients, how many no-shows that they've had in the past. And for example, in nephrology, when they hit a 50% threshold, they immediately were scheduled towards the no-show slots. And I mean, we have a no-show initiative, and it's throughout several of pediatrics, and it's a constant, you have to keep your finger on the pulse. And, you know, there's different initiatives with the no-show program that we're doing, but it's a matter of just monitoring in the system, and yes, it does track the threshold.
Okay, Pat.
Hi, Patricia McLaughlin from the National Patient Safety Fund. So red means it's on and green means it's off, just FYI.
And hopefully we're not colorblind.
Patricia McGaffigan from the National Patient Safety Foundation. On this concept of no-shows, I'm curious, how much data do we have on why patients don't show up? And I'm sure it's very multifactorial, but how much of it is related to their frustration with the system? And, you know, just kind of knowing repeatedly that every time I go to see a certain physician or a clinic, you know, I'm going to be sitting there, you know, hanging out, reading that probably not even 6-month-old journal, but 2 years in a waiting room. But what do we know about that, and is there something that we can learn that would feed into some of the solutions that we need to be thinking about?
We're about 9 months into innovation project that we're doing, studying complex patients and designing a different care model for complex patients. I would say that the stories we've heard, the studies that we've done, there are typically, one or very few ways to do things right, but there's a lot of causes for when things don't work. And what we've learned from our complex patient work is that it can be comorbidities, it can be transportation, it can be child care, it can be, in Wisconsin, a snowstorm or icy roads. It could be a variety of reasons why people do not show. And I think that we're wrapping this into changing our paradigms, extinguishing the word noncompliance, because basically patients who don't show or patients who are not getting good results with, we haven't discovered what their barriers to health are.
Great. Okay, our time is coming to an end. I'd like to thank everyone and perhaps encourage our systems engineers to speak up. We heard a lot from clinicians, but Pascal, as I was hearing people talk, I was thinking of your SEEPS model that technology, processes, culture, all these areas got into play here, and also the boundaries we place on the system. I think put a lot of implications of, is this the CLISIT, or do you even broaden it to home, and how those all interact, and then the measurement systems. But Susan, this discussion reminded me of the article you published in Health Affairs, where you interviewed, or not you, but the journal published an interview of Dr. Don Abedian on his deathbed, who was asked, what's the secret of quality now that you've devoted your life to it? And his eloquent words were, the secret of quality is love. If you have love, you can work backwards to fix the system. And that thought of kind of approaching it that way seemed to permeate. So I thank you for a really lively discussion. And I think we have a break now here. Is that correct?